This is the matrix calcaneal fracture plate. It comes in rights, as this one is here, and also in lefts. And it also comes in different sizes from small, medium to large, allowing the surgeon to pick the implant that best fits over the lateral aspect of the calcaneus. This is a pre-contoured anatomic calcaneal plate with features that are unique. It has locking screws available throughout the plate, particularly right underneath the posterior facet of the subtalar joint. It also has a feature of non-locking capabilities throughout different holes in the plate to allow for the plate to be directly opposed to the lateral aspect of the calcaneus. The plate set comes with towers that are locking onto the plate, which can be used as handles to allow the surgeon to manipulate the plate and put the plate exactly where they would like it. When considering fixation of the calcaneal fracture, you must make sure that the soft tissue envelope is ready for surgery. That means that there should be a positive wrinkle test. When dorsiflexing the ankle, you should be able to see wrinkles throughout this area of the foot in order to know that there is enough subsidence of the edema for surgery to be undertaken safely. In calcaneal fractures, the position of the incision is very critical. When we look at the anatomy, the calcaneal approach is para-Achilles, extending down to the glabrous portion of the skin in a curved manner, and then extending along the glabrous portion of the skin all the way past the CC joint if needed. Evaluation of the X-rays and the CAT scan prior to surgery will allow you to know how extensile you will need to be both in the proximal and distal aspects of the wound. When doing your surgical approach, keep in mind that the sural nerve oftentimes comes into the anterior aspect of the flap, and so you can see branches of it both in the proximal extent of the incision as well as the distal extent of the incision. We try to do the calcaneal extensile approach with a minimal touch technique. A 15 blade is used to create the incision through the skin. The incision is taken all the way down right to the bone itself. Oftentimes, a number of passes need to occur in order to get down to the bone itself. Once you've approached the bone, you want to elevate the soft tissues directly off the bone itself. And you can hold the skin with Adsin pickups or rat tooth pickups, depending on surgeon preference. As you elevate, you want to elevate directly off the bone itself. As you elevate, you must keep in mind that the peroneal tendons themselves come into the anterior flap. So as you elevate subperiosteally, you will need to keep that in mind so that you do not cut the peroneal tendons. This dissection can be done sharply with a knife. Alternatively, it can be done with a periosteal elevator. The goal of the surgical approach is to elevate the entire flap all the way to the subtalar joint. once you are able to see the tip of the fibula, the posterior facet of the subtalar joint, and even the talar neck or the cuboid, you know that you have dissected enough. Next, we want to put some K-wires into the cuboid, the talar neck, and the fibula in order to hold our flap in a no-touch technique. Plate benders are available to allow you to bend the K-wires to facilitate getting the soft tissues out of the way. The first K-wire is placed into the cuboid. The second gets placed into the talar neck. And the third can be placed into the talar body or the distal tip of the fibula. At this point, you can complete your dissection. And again, you should be able to see the subtalar posterior facet in the deep aspect of your dissection. When we talk about calcaneal fractures, you will see a lateral wall blowout. Using a periosteal elevator or even a saw, you can elevate the lateral wall of the calcaneus and take the lateral wall off the body and place it on the back table to be used later on. Once the lateral wall of the calcaneus has been removed, you will now focus on identifying fracture fragments and performing a reduction. Our reduction is performed from the medial aspect or the deep aspect of the wound to the lateral aspect or superficial aspect of the wound. As you piece different parts of the calcaneus together, you may use K-wires to provide provisional fixation. Now, oftentimes with the calcaneus, the heel will be shortened, widened, and invarus. Once you identify fracture fragments, the first piece that you oftentimes will need to reduce is the posterior inferior tuberosity. This can be done with a Schanz pin being placed in a lateral to medial direction in the posterior inferior tuberosity. As we come through the calcaneus, you have the choice to come and puncture through the medial aspect of the foot or just leave the Schanz pin in the posterior inferior tuberosity without violating the medial soft tissue envelope. With the Schanz pin in place, you can pull the heel out to length into valgus and help perform the reduction. Once you have the reduction where you like it, the next step is to pin the posterior inferior tuberosity in place. Your options are to pin directly into the talus, or you can pin into the cuboid, or sometimes you can pin into the talar body itself as well. Depending on the fracture pattern that you are dealing with, you have choices as to where you would like to make your provisional fixation with the pins. Now, you can use as many pins as you need to hold your reduction in place while you complete the fracture fragment identification, mobilization, and reduction. Once you reduce all of the fracture pieces, you can remove the Schanz pin. Removal of the Schanz pin allows for estimation of the size of the implant that will be used for your calcaneal fixation. Once you have placed as many K-wires as needed to provisionally hold your fixation, you can, under fluoroscopic or X-ray guidance, determine if you will use a small, medium, or large calcaneal plate. Using the locking tower as a handle, you can then manipulate the implant in the position that you so desire. Checking under radiographic visualization on a lateral view will allow you to estimate the correct small, medium, or large size implant that might be necessary. Also, checking a Harris heel view will allow you to ensure that you have corrected the hindfoot varus that can be seen with calcaneal fractures. Once you have decided the location and size of your implant, you can start off your fixation using a cannulated 4/0 screw that will go through the plate into the sustentaculum talus. Now, this K-wire can be checked radiographically on a Harris heel view to ensure that you are in the sustentaculum talus itself and not in the inferior aspect of the sustentaculum talus. Once it is checked radiographically for position and you confirm that you like the reduction, the position of the plate, and the position of the 4/0 guide pin for the screw, you can then measure the screw itself to check the size of the screw, and then you will over drill your guide wire and place your cannulated 4/0 screw. We will place the cannulated 4/0 screw in the middle posterior facet holes, as this hole is not threaded and will allow for the plate to be held directly against the lateral the lateral wall of the calcaneus. Once you have measured your screw, you can put the cannulated screw over your guide wire and bring the screw directly against the plate, bringing the plate directly opposed to the lateral to the lateral calcaneus. Next, you can remove your guide wire, and now you have options to complete screw fixation. You can place screws in any screw hole available depending on the fracture fragments that you're dealing with. You certainly want to make sure you apply 1 or 2 screws in the posterior aspect of the calcaneus, 2 screws into the anterior process of the calcaneus, and complete the rafters underneath the posterior facet of the calcaneus to allow for stable fixation. The next screw we will be placing will be into the posterior inferior tuberosity. So we will drill into the posterior inferior tuberosity. Through both cortices. Using our depth gauge, we will check the depth of the screw and place the appropriately sized screw. Again, you can complete whatever screws you feel depending on the fracture fragment you're dealing with. The posterior facet screws should be placed so that there is a strong rafter right over. Again, we will drill. Measure with a depth gauge. And place the appropriately sized screw. In these locking holes, you have the choice of a locking screw or a non-locking screw. Once all of your fixation is complete, you can remove the K-wires. Once the K-wires have been removed, you can check final x-rays on lateral views as well as the Harris heel view to make sure your reduction and your implants are where you would like them. You will now close your incision with 2 absorbable sutures for the subcutaneous tissues and nylons for the skin.